Hello. So today we are going to start our series of gynecological pathology, and in which are first of all discussing vulvar pathology. So first of all, the term vulva. What does the term vulva means? So vulva is basically and anatomically includes the skin and mucosa of the female genitalia external to the hymen, which includes the area like labia majora, labia minora, mons pubis, and vestibule, and usually it is surrounded by squamous epithelium. So disorders of the vulva most frequently are inflammatory, and which makes them much more uncomfortable as compared to serious. And malignant tumors of the vulva, although they are life-threatening, are usually very rare. So first of all, we will discuss the disorder vulvitis, which is the inflammation of the vulva. And one of the most common cause of vulvitis is the reactive inflammation in response to an exogenous stimulus, whether an irritant or an allergen. So when there is an irritant in the form of exogenous stimulus, so that disease is usually called contact irritant dermatitis, and when an allergen is a sort of exogenous stimulus, so that disease is called contact allergic dermatitis. So scratching, which usually occur due to that, induce a trauma due to intense itching of the nature of this disease, and which usually exacerbates the primary disorder. So contact irritant eczematous dermatitis manifests as well-defined erythematous weeping lesions, or they can also be in the form of papules and plaques having crusts. So it may be due to a reaction to urine, soap, detergents, antiseptics, deodorants, or alcoholic products. So allergic dermatitis has a similar clinical appearance and may result from allergy to perfumes, additive in any cream, lotion, and soaps, chemical treatments on clothes, or some other antigens. So vulvitis also may be caused by infections which are usually sexually transmitted. For example, the most important of these infectious agents in US are human papillomavirus (HPV), the causative agents of condyloma acuminatum, and vulvar intraepithelial neoplasia. So human papillomavirus is usually the causative agent of condyloma acuminatum and vulvar intraepithelial neoplasia. Infectious agent can also be herpes simplex type 1 and type 2, and this virus usually transmits the genital herpes with its characteristic vesicular eruption. Neisseria gonorrhea is also another infectious agent, and it's a cause of suppurative infection, pus-forming infection of the vulvovaginal glands. There is another Treponema pallidum, which is classically known as the cephalus pathogen, in association with the primary chancre, painless ulcers at the vulvar site of an inoculation, and candida can also be a potential source of vulvitis, usually in diabetics. So an important complication of vulvitis is the obstruction of the excretory ducts of the Bartholin glands, and this blockage may result in the painful dilation of the glands, which is a Bartholin cyst, and abscess can be formed. So let us discuss much more about the Bartholin cyst. Bartholin cyst is basically a cystic dilation of the Bartholin gland. So one Bartholin gland is present on each side of the vaginal canal. So on each side of the vaginal canal there is Bartholin gland, and it produces mucus-like fluid that drains via duct to the lower vestibular area in the vagina. So it arises due to inflammation and obstruction of ducts of the glands, and usually occur in the women of reproductive age due to increased sexual related activities, and it presents as unilateral painful cystic lesion at the lower vestibule adjacent to the vaginal canal. Now we will start discussing about non-neoplastic epithelial disorders of the vulva, which includes two most common forms. First is lichen sclerosis, and other is the lichen simplex chronicus. So let us start discussing by lichen sclerosis. So the epithelium of the vulvar mucosa which we have said that epithelium is usually squamous in nature, so may undergo atrophic thinning or hyperplastic thickening. So they can undergo both thinning and thickening and results in these two disorders which I mentioned previously, lichen sclerosis or lichen simplex chronicus. So lichen sclerosis, what is lichen sclerosis? So it is characterized by thinning of the epidermis. So the skin layer is composed of epidermis and dermis, so it is basically the thinning of epidermis. The epidermal layer will be thinned. There will be the disappearance of ratty pegs. So what are ratty pegs? They are basically invagination of epithelial layer into the connective tissues. So that layer is usually disappeared in lichen sclerosis, and then there are hydropic degeneration of the basal cells, just like in atrophy, which you are finding out that there will be hydropic degeneration of the basal cells. You will also find dermal fibrosis and scant perivesicular mononuclear inflammatory cell infiltrate. So lichen sclerosis appears as a smooth white plaques, which is also termed as leukoplakia, or it can also form like papules that in time extend and coalesce together. So when the entire vulva is affected, the labia somewhat atrophy and get stiffened, and the vaginal orifice get constricted due to that stiffening. So lichen sclerosis occurs in all age groups, but the most commonly postmenopausal women are affected with this disorder. So the pathogenesis is uncertain, but the presence of activated T cells in the subepithelial inflammatory infiltrate and the increased frequency of autoimmune disorders in affected women usually suggests that there might be an autoimmune etiology. So lichen sclerosis is usually benign, but very small percentage of women, like 1 to 5%, presents with symptomatic lichen sclerosis that usually develop into squamous cell carcinoma of the vulva. So histologically, the common findings which you have to remember in the lichen sclerosis is that thinned epidermis, hydropic degeneration at the basal layer, then there is sclerotic stroma, and then there is dermal inflammation. And very rarely 1 to 5% of the women can progress towards the squamous cell carcinoma of the vulva. Now the second disorder is lichen simplex chronicus. Lichen simplex chronicus is marked by epithelial thickening, particularly of the stratum granulosum, and there is hyperkeratosis which is found. So let us discuss the skin layers. So the layer of the epidermis is divided into 5 layers. First is stratum corneum, stratum lucidum, followed by stratum granulosum, followed by stratum spinosum, and then at the end there is stratum basale. Then there is a dermis, and then there is a hypodermis. So what we have said that in lichen simplex chronicus there is marked epithelial thickening primarily in the stratum granulosum. So in the third layer there is usually that thickening. Alongside thickening there is also that hyperkeratosis, which is a condition marked by thickening of the outer layer of the skin, which is made of keratin. So lichen simplex chronicus is having that epithelial thickening and hyperkeratosis. There will be the increased mitotic activity in the basal and suprabasal layer. However, there is no epithelial atypia, which confirms that when there is no epithelial atypia, so there is low chances of carcinoma. So leukocytic infiltration of the dermis is sometimes pronounced in lichen simplex chronicus, and these non-specific changes are a consequence of chronic irritation often caused by pruritus related to an underlying inflammatory dermatosis. So lichen simplex chronicus appears as an area of the leukoplakia. Also it appears as a leukoplakia, just like we've discussed in lichen sclerosis. So lichen simplex chronicus is also appearing as that whitish black type of area. With isolated lesions, no increased predisposition to cancer has been found, but lichen simplex chronicus often is present at the margins of the established vulvar cancers. So, when it is present alongside the established vulvar cancers, so therefore there is a hypothesis about the possibility of an association of lichen simplex chronicus with a neoplastic disorder. So lichen sclerosis and lichen simplex chronicus may coexist in different areas of the body in the same person, and both lesions may take the form of the leukoplakia or the white patches. So similar white patches or plaques are also seen in a variety of different benign dermatoses such as psoriasis and lichen planus as well. Also, in some of the malignant lesions of the vulva such as squamous cell carcinoma and sato, in an invasive squamous cell carcinoma, this leukoplakia may be the only form of the lesion will found. So therefore biopsy and microscopic examination are needed to differentiate these clinically similar appearing lesions. So the hallmark features of the lichen simplex chronicus on microscopy will be the presence of hyperkeratosis, thickened epidermis which is also called acanthosis, and the third important thing will be dermal inflammation. Now we will discuss about the tumors of the vulva, which includes condylomas. One, second is carcinoma of the vulva, and the third is extramammary Paget's disease. So these are the three tumors which are usually found in the vulva. So first of all we will discuss about the condylomas. So condyloma is the name given to any warty lesion of the vulva. And most such lesions can be assigned to one of the two distinctive forms. One form is known as condyloma lata and the other form is known as condyloma acuminata. So condyloma lata, which is not commonly seen these days, it is usually flat, moist and minimally elevated lesions that occur in the secondary cephalus. The other lesion is condyloma acuminata. It may be a papillary and distinctly elevated or somewhat flat or rugose. So by the term rugose we mean wrinkled appearance. So it might be having that wrinkled appearance or it will be completely flat. And condyloma acuminata can occur anywhere on the anogenital surface. Sometimes it's a single but most commonly like multiple lesions. So when located on the vulva, they range from a few millimeters to many centimeters in diameter and are red pink to pink brown in color. So condylomas on histological examination, the characteristic cellular feature is the presence of the coelocytic changes. So coelocytosis is the hallmark features of condyloma, which is characterized by perinuclear cytoplasmic vacuolation and wrinkled nuclear contours. And that is the hallmark of human papilloma virus HPV infection. So on histological examination, the characteristic cellular feature is coelocytosis, a cytopathic change characterized by perinuclear cytoplasmic vacuolation and wrinkled nuclear contours that is hallmark of HPV infection. So condyloma acuminata are strongly associated with low risk subtypes of HPV 6 and 11. So HPV usually have that low risk subtypes as well as high risk subtypes which we will discuss in the carcinoma of the vulva. So low risk subtypes are 6 and 11 and they are associated with condyloma acuminata. So HPV can be transmitted during sexual intercourse, and identical lesions occur in men on the penis and around the anus. So HPV 6 and 11 infections carry a low risk of malignant transformation and hence vulvar condylomas do not usually progress to cancer. So condyloma is basically a warty-like lesion usually associated with the human papilloma low risk subtype 6 and 11 and they does not progress to malignant tumors. Now the second one, carcinoma of the vulva. So carcinoma of the vulva represents about 3% of all female genital tract cancers occurring mostly in women older than age 60. So it's usually common in older population. And approximately 90% of carcinomas are squamous cell carcinomas and the other tumor types which may originate are usually adenocarcinoma or basal cell carcinoma. So carcinoma of the vulva majority of the time is the squamous cell carcinoma. However, you might find adenocarcinoma or basal cell carcinoma in very rare cases as well. So there appears to be two distinct forms of valvular squamous cell carcinoma, and the less common form is related to high-risk HPV strains. So high-risk HPV strains usually are 16, 18, 31, 33, and low risk, which we have discussed previously in condylomas, are usually 6 and 11. So the less common form is related to high-risk HPV strains, usually 16 and 18, and occurs in middle-aged women, particularly in cigarette smokers. So in this form, which is usually less common form, the onset of carcinoma often is preceded by peak and serious changes in the epithelium, which is termed as vulvular intraepithelial neoplasia. So the first lesion which appears is vulvar intraepithelial neoplasia, which may progress towards carcinoma of the vulva, full-blown carcinoma of the vulva. So vulvar intraepithelial neoplasia progresses in most patients to greater degrees of atypia and eventually undergoes transformation to carcinoma in situ, full-blown carcinoma. So vulvar intraepithelial neoplasia means the nuclear atypia will start appearing, atypia of the cell will start appearing, but when it becomes the degree of atypia when increases, so it will convert into the carcinoma in situ. So however, progression to invasive carcinoma is non-inevitable and often occurs after many years of valvular intraepithelial neoplasia. When it converts into carcinoma in situ, it can progress towards invasive carcinoma, but after many years. So environmental factors, as previously discussed, like cigarette smoking and immunodeficiency, appears to increase the risks of such progressions. So first is the lesion appears, which is known as vulvar intraepithelial neoplasia, which can convert into carcinoma in situ, and then carcinoma in situ can become metastatic carcinoma. But this is the less common form of carcinoma of the vulva. So second form of vulvar carcinoma that usually occurs in the older women, but which is not associated with human papilloma virus, but it's often preceded by years of reactive epithelial changes, principally in lichen sclerosis. Just like we have discussed lichen sclerosis, so there is that reactive epithelial changes due to inflammation. So this is the second form of vulvar carcinoma that can occur. One is human papilloma virus, which is associated with human papilloma virus, and the second one is associated with lichen sclerosis. So the overlying epithelium frequently lacks the typical cytological changes of valvular intraepithelial neoplasia, but it may display subtle atypia of the basal layer, and basal keratinization will occur. So when this sort of tumor will invade, so it will be well differentiated and it will be having highly keratinized sort of tumor. So the both of these tumors may remain confined to their site of origin, but ultimately they can invade and spread, and first of all they will spread to the regional lymph nodes. And the risk of metastasis correlates with the size of the tumor and the depth of invasion. So women with tumor less than 2 cm in diameter have about 90% 5-year survival rate after radical excision, whereas only 20% of those with advanced stage lesions survive for 10 years. So a bit about morphology of vulvar carcinoma. So vulvar intraepithelial neoplasia and early vulvar carcinoma manifests as area of leukoplakia, just like we discussed previously. It's like a white patches in the form of white patches of epithelial thickening. So in about 1/4 of the cases, like in 25% of the cases, the lesions can be pigmented due to the presence of melanin. And over time, these areas are transformed into overt exophytic or ulcerative endophytic tumors. So exophytic tumors are basically the tumors when the growth of the cancers occurs principally above the surface epithelium, and endophytic tumors when the tumor growth appears principally below the surface epithelium. So in vulvar carcinoma, we it may convert into exophytic tumor or it can convert into endophytic tumor as well. So HPV positive tumors often are multifocal and warty and tends to poorly differentiate into squamous cell carcinoma, whereas HPV negative tumors usually are unifocal and typically manifests as well differentiated keratinizing squamous cell carcinoma. So the poorly differentiated tumor is HPV related and well differentiated tumor is related with lichen sclerosis. So let us discuss the last tumor of the vulva, which is called extramammary Paget disease. So Paget disease is an intraepidermal proliferation of malignant epithelial cells that can occur in the skin of the vulva or nipple of the breasts. So extramammary, like Paget disease, is found in bones, it is found in breast, it is found in vulva. So we will differentiate the Paget disease of nipple of the breast and the skin of the vulva. Both of these disorders occur in the skin. So it's intraepidermal proliferation of the malignant epithelial cells in the skin of the vulva or the nipple of the breast. However, unlike in the breast where Paget disease is virtually always associated with underlying carcinoma, a majority of the cases of vulvar, which is also called extramammary Paget disease, have no demonstrable underlying tumor. Instead, vulvar Paget cells most commonly appear to arise from epidermal progenitor cells. So, are you noting the difference between Paget disease of vulva as compared to nipple of the breast? That in the Paget disease of the nipple of the breast, you will always find some underlying carcinoma. However, in the vulva, you will not find that underlying carcinoma most commonly. Only occasionally Paget disease in this location is accompanied by subepithelial or submucosal tumors arising in adnexal structures just like sweat glands. So the tumor, if it will be found in some sort of adjacent organs like structures like sweat glands. So Paget disease manifests as red scaly crusted plaque that may mimic the appearance of the inflammatory dermatosis or dermatitis. On histological examination, the large epithelioid cells with abundant pale, finely granular cytoplasm and occasionally cytoplasmic vacuoles infiltrate the epidermis singly or in groups. So the laboratory investigations or the lab investigations which has to be done to differentiate this Paget disease from vulvar and melanoma is PES or periodic acid shift staining. So the presence of mucin is detected by periodic acid shift staining. So PES staining is positive in the Paget cells, however PES staining is negative in the melanoma. So the presence of mucin, which is detected by PES staining, is useful in distinguishing Paget disease from vulvar melanoma, and vulvar melanoma will lack the mucin. Similarly, another important marker is the presence of the keratin. It is also known as an intermediate filament. So keratin is an intermediate filament which is characteristics of epithelial cells. So keratin is positive in Paget cells, and in melanoma keratin will be negative. And then there is S100 protein. So S100 protein is characteristic of melanoma, however in Paget cells S100 protein will be negative. So these are three markers through which you can differentiate vulvar melanoma with vulvar Paget disease. So intraepidermal Paget disease may persist for years or even decades without evidence of invasion. However, when there is an associated tumor involving skin appendages, the Paget cells may invade locally or ultimately metastasize. And once metastasis occur, the prognosis is poor. So this concludes our podcast related to vulvar pathology.